Good morning, all of you. I'm Dr. Marisol Iñiguez from Guadalajara, Mexico. First of all, I want to say thank you to CyberSight for the invitation and give me the opportunity to be with you this day in this hour of the morning here in Mexico, 8 a.m. So I'm going to talk you about some orbital tumor surgical approach in real patients, in real cases that I have had the opportunity to treat in my hospital, Hospital Civil de Guadalajara, here in Guadalajara, Mexico. So we are going to begin with a little boy. Our first patient is a 2 years old little boy which his main problem is a history of 2 months, and his mom says that the eye is going out. The left eye is going out. The little boy says too. And in this picture, we can see in the first vision of the situation patient doctor, in the first visit, we can see the proptosis of left eye, pseudotosis. He had a limitation in the abduction movement of left eye and red eye in the intermittent form. So the first that we have to do in all kind of patients, even if they are pediatric or adult, if they are hospitalized or they are like common consultation, is to see what is the visual acuity. So in the right eye, we have central fixation and 20/20. For the left eye, we have central fixation and 20/60. Even he's a 2-year-old boy, he has very good attitude, and we could take the visual acuity as an adult person. So you don't have to be with the idea that if it's a pediatric patient, it's going to be difficult. So all kind of patients must have the visual acuity at the beginning. In the skioscopy, we can see an astigmatism in the left eye that could be maybe provoked by the proptosis and the pseudotosis. For the eyelids, eyebrows, and eyelashes, I would like to see the picture again. We can see that the conjunctiva in the right eye is normal. In the left eye, in the temporal zone, we have redness. And we usually put these little marks in different colors for the students or the fellowships that are starting in my hospital. And with these marks, we can see that it's not an illusion. It's not like the mom is making out a history. It's a real situation where the eyelid is coming down. If you see the distance between the visual reflex in the cornea and the distance that goes to the board of the eyelid, we can see a difference in which the left eye is a real ptosis. Always we can see the sulcus line of the eyelid. So in this moment, we could think in a paneurotic ptosis, but we have to be sure of the movement and the quality of the elevator muscle. We can see too that the eyeball, the left eyeball is descended, is down, and we have a big volume in the inferior eyelid too. So we continue with the exploration. The intracular pressure is about 12 millimeters in the right eye, 16 millimeters in the left, taken with eye care. In the ophthalmometry, we have 16 millimeters right eye, 19 millimeters in the left eye. So we have an important difference here. And this picture is very useful because sometimes maybe we can think that it's like the position of the head during the picture, or maybe the patient moved during the exploration, but with this position of the head in Worm's position like this, we can see that actually there is a proptosis. Even if you don't have the exophthalmometer, you can see with that position of the head that is a really proptosis in the left eye. And in the axial vision, we can see the photographs that we have the proptosis in the left eye, as the mom said. So, what is going to be our approach? For the beginners, ophthalmologists could be like heavy, like scary, but if you continue with the protocol of always make a complete clinical history and follow step by step the diagnosis, you are going to be fine, and your patient is going to be fine too. So in this tomography, in coronal slide, in coronal projection, we can see here the tumor is involving and is touching the eyeball, and the temporal wall is eroded. So we have to be like very carefully because we have a really short story. We have a 2-month story, and now with 2 months, we have the temporal wall eroded. So we must be hurry up with this patient. In this other projection, like more intraconal, we can see that the walls in the frontal temporal zygomatic is totally eroded. And in the actual projection, we can see even a little communication between brain and orbital tissues. Our mass is a not well-limited bordered mass. So we have here a few points that cause maybe it's a malignancy mass, and we must be very fast with the surgery to make diagnosis and treatment. Thinking about it's a 2-year-old patient. Here is another projection where we can see totally eroded that temporal wall. More eroded. And here we are going to see the approach that we did with this little patient. Oh, sorry. It's a video. Here we have our patient. We are going to make a temporal osteotomy. We open the periosteum and we take a piece of temporal bone, and we arrive to the mass. If you see the mass, it has no capsule, so we have to take out in little pieces. But fortunately, we take off all the tumor. After that, we close the periosteum with Bicryl 6O, separate points. And because it's a little guy, we used to put this for not have a retrobulbar hemorrhage. So we finish the procedure. For 1 day of evolution, the boy is well. 8 days. 15 days of evolution, we can see that the movement of the eyes are conserved. The pupil reflex is good. The movement is really good. He's well. Now we have the piece complete to make a histopathologist examination, and he's in a very good way. So our histopathology result talks about histiocytosis of Langerhans cells, unfortunately completely removed. And these kind of patients, if we diagnose them in a very quickly form, they have a very good prognosis. And now he has 3 years old, he's well, he's going to school, to the kindergarten. So we could have a very good diagnosis and treatment in a very good way and in a good time. So we don't have to subestimate this kind of patients. Even if you don't have the resources, you can do a lot if you have a very good clinical history, a good exploration, and if you can do that, you have to refer the patient. Our next patient is an adult. She's a 52 years old woman. And if you can see, I'm going to come back a little bit, the limitation of the movement of the left eye. We are going to see at the end, limitation in the left eye. For the left and right movement is okay. And she has a proptosis that is evident. And she has also a history of diplopia. Here we have, I'm going to make a pause in the tomography. Here we have the actual projection, and we can see a very huge mass behind the eyeball, intracranial, but fortunately it has very good limited borders, so it talks about a benign lesion. Also, if you can see the temporal wall, the wall is not eroded as the other case of the 2-year-old boy. This wall is like remodeled. So it talks about chronicity. It talks about maybe the patient noticed is like 1 year before, but here is a mass that had been there for a long, long time. So it provokes the remodelation of the temporal wall. Now we are going to have the coronal projection. Here we have the tumor. It's behind the eyeball and it's like located more up than down or than temporal. So in this tomography, we can see where is going to be the most effective way to arrive to the mass. Maybe you are going to have like combined approaches and it's well done. So always you have to be, before going to the surgery, always you have to be sure and have radiology images. Sorry. And in another coronal projection, we can see that the mass is almost near to the apex, the orbital apex, inside the cone, surrounded by the muscles. So we have to be very careful. And I insist, even if you see these kind of tumors that are big, that are for difficult approaches, that is difficult to get inside, don't be afraid, just follow the protocol and always try to do the simple thing. So we are going to arrive another time in temporal way. Okay, but always we have to mark the eyelid sulcus just in case, to be prepared. If you notice, we mark it in the natural sulcus to not to make another heel. And we are going to approach in temporal wall. So we are going to mark an italic S down the eyebrow. And here again, we have separated the tissue until arrive to the periosteum that we open with the scalp. After that, we remove the periosteum to arrive to the bone. Very carefully, because remember that you have an eyeball, a functional eyeball there. And after that, with a lot of care, we use an element to break the bone. This piece of bone, we have to be very carefully and keep watching it, because we are going to replace after the surgery that part of bone to complete the orbit. Here, even here, you can see the mass. It was not too difficult, even it's so big. And we are going to remove very carefully. After that, we make some measures for the histopathology service. And the ball is almost 25 millimeters for each side. Now we incorporate that piece of bone, and we like to to suture the bone with a little holes that we made with the motor. And here we have our patient in the 8 days after surgery. Well, this is our lunch here in Tequila, where tequila is made for all the world. So if you can see, it's another temporal way to arrive. It's a different patient, different age, but the technique is more or less the same. Here we have another patient with, well, the last patient was a schwannoma. This patient is an hemangioma, and it's a 45 years old man that arrives with a proptosis history of 1 year, diplopia, and well, the cosmetic aspect is important too. So one more time, we make some marks in the photographs to evidence for the patient and for the doctors that are studying with us that the right eyeball is down compared with the left. And this image in the superior photograph, we can see the limitation for the up movement, even for the right movement, the function of the lateral muscle. And well, we have to do something one more time. It looks like so big, like so different, so difficult. But remember, if you follow the instruction, if you follow the protocol, you are going just fine. Here we have our tomography. In this projection, we can see that it's a contrast tomography, and the lesion has more reflex, so it seems to be a vascular tumor. And we can see that it's pushing down the eyeball in the left image. But another time we can see that the wall is not eroded, that it's a good sign, a good situation. It speaks us about something that it's not malignancy. And in the axial position, we can see the tumor that is not eroded the temporal wall, but it's touching the muscles and maybe the optical nerve. So we have to be very carefully here, speak very well with the patient, have a lot of confidence and a lot of communications with the patients, because yes, he's a long story of proptosis and diplopia, but after the surgery, he can still with the diplopia, he can lose a little bit of visual acuity, and he has to be conscious about this and about the risk of the surgery. It's the same approach with an italic S in the temporal wall of the skin. Mark the sulcus of the eyelid if it's necessary to arrive at an approach by 2 sides. Then we open it, we arrive to the periosteum, and we have to be very carefully with the external muscle, because if you don't have a very good equipment of strabismus in your team, you are going to have a little bit problems with the movement of the eyeball after the surgery if you are not very carefully, or maybe if the mass is too big. So always have a good friend of strabismus surgery. And here we have the mass, it's a little bit bigger than the other. And here is the patient 8 days before surgery. If you can see, the eyeball is not completely in parallel, but it's better than before. And we have a little bit of edema and ecchymosis, but the result is very well. The diplopia is not more on his life. And he recovered 2 lines of vision. So it's a good result. Here we have another different case. It's a little girl, 2 years old, too, that arrives from the oncology service. She has leukemia, but also the mom begins to show, to see the proptosis of right eye. She arrives to the service with a magnetic resonance. And well, it's very evident that we have a mass in the temporal region, near to the muscle, pushing the eyeball, that it's eroding the temporal wall. So, well, we have a different diagnosis, but the approach is the same. Unfortunately, with this early diagnosis, the patient received the chemotherapy in time and form, and now she's with a regular life. She's taking ballet class, so she's really good. Well, for the eyelid surgery approach, obviously this approach is going to be when the mass, we can see it in the studies, up of the eyeball. So that is going to be the easiest form for not making another scar and to make a really good, fast, and efficient approach. So this is a very good case, easy in a moment, because in a way, because this is a 14-year-old girl. The mass is not provoking limitation of the movement, is not provoking limitation of the visual acuity, but cosmetic is a huge situation that we must to solve. Most of the time in public hospitals like mine, they don't prioritize the cosmetic situations, but here in these patients, for 14 years old, I think the emotional situation is going to be very, very huge if we don't do something. So the tumor is not so aggressive. The tumor is not malignancy, but emotional, she is going to be improved a lot. So she has a very good way to access. Here we have the tomography, sorry. And in a coronal projection, we can see the tumor is well delimited, is not pushing the eyeball. So maybe functional is not a surgical patient, but cosmetic, it has all the chance to improve. So we get inside of the sulcus and very carefully we remove the tumor. Even if it's benign, we don't want to push up or blow out the tumor, because if the tumor blows out, there is going to be a lot of inflammation because it's dermoid cyst. Here is the 8 days post-surgical. And here she is at 14 days after surgery. And after that, she had her party, her 15 years old party here in Mexico. The big party for the girls is at 15 years old. So I get invited. It was a really good party. Well, our next patient, well, I can see a lot of questions here. Okay, the diagnosis is the pathology. I sent it right. Okay. Well, so this patient, the main problem is our third opinion, because he has been treated in Tamaulipas. It's another state here in Mexico at the north. Does my eye could be saved versus observation versus enucleation. In his town, they just tell him that they could enucleate the eyeball or just observation. So he wants to improve his physical appearance, to improve the visual acuity, and also he has a story of itching, burning, and abnormal discharge of the right eye. In the pathology history, he has a lot of allergies: penicillin, trimebutine, trimethoprim, sulfamethoxazole with cockroaches and cats. This is important because of the final diagnosis. You are going to see why. And here's the ophthalmological history of this little boy. The right eye have had mechanical ptosis since he was born. But if you can see the evolution of the photographs, he always had the visual axis free. So it means that he has not amblyopia of the right eye. And in the other hospital, they want to make an enucleation. So we have to put attention here. And at 9 years old, I mean, after all the development of the visual acuity, the eyelid tumor covers the visual acuity, and then they cannot move the eyelid. And in Tamaulipas, they said that they have neurofibromatosis, but it not makes sense if they have neurofibromatosis, maybe how they want to remove the eyeball. So here we have the patient. If you can see the expression, he's like mad. After see a lot of doctors, he doesn't want to cooperate, but we can see the right eye, that the eyelid is very big, is bigger than the other. It's so big that they cannot move the eyelid, they cannot open it. And these measurements are very important for us in oculoplastic surgery, because in all these marks, we can see that there is 0 millimeters of elevator function muscle. He doesn't have the natural sulcus of the eyelid. He has a lot of secretion in the eyelashes. So with this kind of tumors and the history of the patient, we must to make the transilluminization. And with this proof, we can see that maybe it's a vascular tumor. So if we are thinking in a vascular tumor, we must have to ask for ultrasonography. And we can see in this study that is a high flush lesion. So after that, we ask for a contrast tomography, and we can see a mass that is hyper-reflected in the totally part of the eyelid. In the axial projection, we can see that the mass is covered the totally part of the portion in the eyeball, but the eyeball is respected. And to decide the therapy, we ask for arteriography, and this arteriography, sorry, we can see that the principal vessel is from the ophthalmic artery. It means that we cannot use sclerosant therapy, because if we use that, we are going to lose the 20/20 visual acuity that he has. So we must arrive and take out the tumor with an open biopsy. He is not a good candidate for sclerotherapy. And with the images and the history, we can talk and we can think that the lesion is an hemangiolympangioma. So we have the approach by the sulcus eyelid. We mark it in the natural sulcus. We separate the tissues very carefully, because remember that it's a vascular lesion. But with all the studies that we asked before, we can see where is the principal vessel to avoid the bleeding. And here we are separating the mass. He's almost removed, but we're going to arrive to the principal vessel. We close it, we use the cauterion, and then we remove the complete mass. After that, we have to search the aponeurosis to attach it in the tarsus, not go through the tarsal conjunctiva to protect the cornea. And then we close the skin with separate points. 8 days before, 15 days after, sorry. And in 15 days, we can see the visual axis free. So it's a good result. He needed a cosmetic surgery after that, oculoplastic surgery. But the important situation here is that now he can use the right eye. Anybody remove the eyeball in the way that they informed in the other hospital in Tamaulipas. And now he's in the high school and he has a regular life. Here we have the sample. The result, the histopathology result talks about an emantial lymphangioma, as we thought, totally removed and negative for malignancy. And here we have a very beautiful photograph of the histopathologist because we have a very representative basal with erythrocytes and another basal with lympha. So in this type of patients, if you see, we use the same approach as the dermoid kyst, but even we approach the same way in the sulcus eyelid, we use a very different way to diagnosis. So the important thing here is a very good, I insist, in a very good clinical history. Remember the allergies of this boy. That's why every time he had a period of allergies or some situations with nose throat problems, the mass get bigger. So that point is very important to make the diagnosis. And if you don't have the time and you don't give the regular time to your patients, you are going to lose these little details. So it's very important to have a very good communications with the patients, with the moms, to have a very good diagnosis. This is another patient in which we arrived by the sulcus eyelid too, but even the approach is the same, the history is different. This tumor is pushing the eyeball, and this patient had neurofibromatosis. So if you see, there's a lot of variety of presentations in these kind of tumors. And I insist, even if you see that like so big, like so aggressive, don't be afraid. Just follow the instructions, follow the protocol, and you are going to be fine, and your patients are going to be just excellent. Here we have another type of approach for floor or transconjunctival. Here we have, Here we have a little 5-year-old boy with a tumor, hysteral tumor of 2 years. So the tumor begins at 3 years old. Sorry. Yes, the tumor is in the inferior eyelid. He had like violet color. He is bigger when he make efforts. So now we have another probably vascular tumor. And here we have the tomography. Fortunately, the wall is not eroded, the inferior wall. And if we can see, is like more reflective tissue. It's a contrast tomography, and the eyeball is fine. It's another case that the functional situation is not involved, but the cosmetic problems that it provokes in the school is higher than the visual acuity that he could lose. So even the visual acuity is fine, we are going to make the surgery because the improvement of the emotional situation of this patient is going to change in 180 degrees. In the actual position, sagittal position, and we arrive very carefully for not lesion the skin. We separate the retractors muscles from the tarsus to arrive to the floor of the orbit very carefully, because remember, it's a vascular tumor. Here we have the tumor. We are going to separate the fat pads. But remember that we are forming medical students. So this chocolate cyst has been pushed up and all this comes out. So we are going to remove the capsule, and this is the boy after 15 days. Well, this is another patient. I have to say that it's not a tumor, but the approach is the same, and it's important to see the difference between these cases. Even if it's not a tumor, you can help this kind of patients in the same way. So it's a little girl, 12 years old, and she said that something get inside my eye, and after that I have double vision. Here is the photographs of the movement of the left eye. We can see a very important limitation for the up and down movement. And another time, we can see the worm's position for a photograph. And yes, she has a little proptosis. We ask for the tomography, and we can see a mass, excellent and very well defined, that appears in the same position in the actual projection. And here is pushing the eyeball, but the medial wall is not altered. And in the sagittal projection, it continues the same form of the mass. So it's not a tumor, we know that, but it's a foreign body that we should remove. So we are going to arrive making a suture in the gray line of the eyelid. After that, we separate the tissues until the floor of the orbit, very carefully to not make another incision in the skin. And with a lot of care, because remember, we have an eyeball there, we have our foreign body. And we have it, finally. It's a marble. I don't know how the marble gets in, but we must believe to the girl that something gets inside the eye. And after that, we close the retractors to the board of the tarsus with Vicryl 6O. And it's a good result. We have here the photograph. She arrives in this condition, and at 15 days after surgery, she's recovering the position of the eyeball and eyelid. Well, for the roof approach or intracranial approach, we have to ask some help for neurosurgery service, because here we have an astrocytoma. We have the resonance that shows that a mass is getting inside the orbit, and it's a little boy of 3 years old. So in this situation, the ophthalmologist cannot get inside alone. We must have a multidisciplinary team that help us. Most of the time, we go together with neurosurgery, ear and throat doctors, dermatologists, because it's a very different approach that it's not for ophthalmologists. So in this photograph, we have the craniotomy, and it's a very good way to arrive to the orbit. Obviously, it's a bigger surgery, more time, more risks, but somebody have to do it. And the ophthalmologist can do it alone. It's very important that always know that you can ask for some help to be sure that your patients are going to be in excellent conditions. And finally, the transcaruncular approach for masses that are in medial wall. Sorry for the audio. Here we are putting some epinephrine in the conjunctiva. After that, very carefully, we are going to arrive to the caruncule. Very carefully, because remember, we have there our medial muscle, and we don't have to ask for the attention of the strabismus cervis. For example, this little baby of 2 days old, I mean, is a newborn baby. He arrives with this cellulitis problem, proptosis, ptosis, chemosis, limitation of the movement of the right eye. And in the tomography, we can see a mass that is occupying the orbital wall, in the medial wall of the right orbit, is pushing the eyeball, is touching the medial rectus. And if you see in the other orbit, they are a little abscess too. It's not an abscess, it's the lacrimal sac. So this little guy has obstruction, congenital obstruction of the lacrimal system, but in a severe way, severe presentation. So it's not a tumor, a real tumor, but it's a mass that is located in the medial wall. So we must arrive in a way that is not to make a healing or a scar in a guy so young. So it's a very good moment to arrive transconjunctival. And here's the video. With the tomography, we know that the brain is safe. And in a transcaruncular way, we arrive to the abscess. It's a lot of secretion. It was 4 millimeters of secretion. And just 1 day before surgery, you can see this little baby in an excellent condition just 1 day before. So it's not a tumor, but it's a very good way to use the transcaruncular approach. And this is another regular case that we have. Another time, I insist, this tumor is not affecting the movement and the visual acuity of this little girl. But imagine this little girl in the school. Obviously, in the emotional form, this tumor is affecting a lot. So that's why we accept to treat them, even if it's cosmetic. This girl, 8 years old, another situation of proptosis. It was an hemangioma. After surgery, 15 days after, this little girl, she has 20/20 of visual acuity with no problems of movement of the eyes. The eyelid is in good position, a little bit of edema, inflammation of the inferior eyelid, but for 15 days after surgery, I think it's a good result. In this image, this patient has 10 years old, this little girl. If you can see the image, the left, see the expression. The expression says a lot. Another time, the acuity, the visual acuity is well, but see the picture in the right hand. See how the expression, how the smile is different, the confidence is different. In this little girl, she had an hemangioma. They treated with sclerosant therapy with no image study. So they provoke telecanthus, they provoke ptosis, and they provoke strabismus. So with the scar, we are going to ask for dermatology service help. But in the right image, we can see that we fix the telecanthus, the ptosis, and the strabismus, and now she's happier than before. Well, sorry about this case, but it's important to mention that. Not most of the times, in few cases, few very sad cases, we have this situation. This girl, 12 years old, arrived to the service with a history of 2 weeks of proptosis in right eye and loss of vision. We proposed to the family to make a biopsy to get inside with general anesthesia. The family didn't want to accept the general anesthesia, even not local anesthesia for biopsy. And they only goes out of the hospital. After that, 2 weeks after that first visit, the girl arrives with this huge proptosis, chemosis, no vision at all, corneal ulceration. And here we have the first resonance that we saw and why we propose to get inside and get a biopsy. So the biopsy was Ewing sarcoma, and we should make a mutilation, an exenteration, mutilate surgery, a totally exenteration, because the tumor was so big and arriving to the brain. So these cases, they don't have to be present in 2021, but unfortunately, we are going to see it in communities with no health access, or in communities with different cultural ways to see the life. I mean, this girl arrived in a good moment and the family didn't accept the treatment. So at the end, we have to do this mutilate surgery. We don't want to do that. We don't like to do that, but you have to be prepared because it could arise. So at the end, it's very important, most for the beginners, always take pictures. Take pictures always, for 2 reasons. You are going to have a very good file and very good material for future conferences. You are going to have your gallery of good prognosis and good cases, but you have to take pictures because most of the time you can have legal problems, and if you have that result, if you have the photographs before, during, and after surgeries, you are going to be protected. So that always, please, everybody has an intelligent phone, so you can take the pictures and be safe. Another very important point is to have radiology before surgery always. Even if you have the idea that it's a common, I don't know, maybe a dermoid cyst, that it's very common, it's benign, it's not a big deal, always ask for radiology images. And other point is everything must go to histopathology examination. Maybe it's obvious, but even if you retire, I don't know, a pterygium, a little mass in the eyelid, a little mass in the skin, always, even if it looks very simple, very inoffensive, always send everything to histopathology examination. Very important to have multidisciplinary approach. Imagine this little girl with Ewing sarcoma, or the other girl with leuemia, or Langerhans cell histopathology. We are the ophthalmologists. we have to be sure that the eyes are perfect, that the visual acuity is fine. But remember that we are not only eyes with legs. We are a complete body. We have to be with a very huge equipment of good doctors like oncology, psychology service, pediatrics, endocrinology, to get the attention that the patients should have. And remember that every patient is unique. If you saw, most of the tumors could be similar, and you can say, oh, it's easy, it's the same approach. It's not a cuisine recipe. You have to be very ethic to think that every patient is a unique and special case that you have to treat in a very important way, as the patient was your family member, okay? And for the end, not forget that Hippocrates said, primum non nocere. If you can do that something, always you can ask for help. So this is the end of my presentation. And now I'm going to answer a few questions. Here we have some questions. Approach to the posterior intracranial orbit apex tumors. Well, I think I said it. Usually we get the mass through a combination of temporal, maybe eyelid sulcus and floor approaches. If this patient is, if these options or combined approaches are not enough, we must ask some help of neurosurgery service, as we did in the astrocytoma case. What's the diagnosis and management of an intracular tumor originating from the optic disc? Well, for intracular tumors in Mexico City, they use brachytherapy and intraarterial chemotherapy, but here in Guadalajara, we don't have that options. So most of the time, these patients with intraocular malignant tumors, we have to send it to Mexico City, to the Instituto Nacional de Pediatría, National Pediatric Institute, because here, unfortunately, we don't have that options. Another question is, do you have any experience with hydatid cyst of the orbit? Well, with hydatid cyst, I don't have any experience, because here Mexico is not an endemic zone for Echinococcus granulosus. In addition, these kind of cysts, they are most common, more frequent in liver. Even the 70% of these cases are in liver, and the 20% of cases are in lung. So it's not very common to find it in the orbit, but I have not had these kind of cases because here in Mexico, we don't have endemic zones of that parasite. Another question is in the nasal approach. Well, I don't have, in my hospital, unfortunately, we don't have endoscopic equipment. My hospital is the most bigger hospital in the west zone of my country. We receive patients from the north, east, and a little bit south of Mexico. It's a public hospital for the persons, for the people that doesn't have any kind of medical insurance. So if we want to make an endoscopic approach, the patient has to pay for it. And most of the time, our patients doesn't have that enough money. Well, here, this is a question of Graves' orbitopathy, surgical descompression. I didn't touch Graves' orbitopathy, but in a surgical descompression, we can make fat or bone descompression, intracranial and extracranial fat descompression, and they evolve very well. And we can make bone decompression of the lateral. I like to do lateral and temporal and medial wall, because it is going to give you even 5 millimeters of changing in the Hertel exophthalmometry without without the risk of provoke diplopia, because remember that if you touch the floor, you can have the risk of make diplopia for the patient. In several cases, we have to make fat decompression and the 3 walls decompression too. Another question, how can we diagnose melanoma? Well, for choroidal melanoma, here we use arteriography and echography in A and B mode. But if you find the melanoma in the eyelids or in the conjunctiva, the diagnosis is clinical. And for the treatment, remember in Mexico, where they use brachytherapy in Mexico City. And here for the excision of the lesion, we can remove the mass or the lesion with 5 millimeters beyond to be sure that it's not going to be a recidivant lesion. After that, we send it to the oncology service. This is a very good question. Well, we have 4 minutes. How does your management change with pediatrics? Well, if you see the cases, I have pediatrics and adult patients. For pediatrics, the technique is almost the same, but in children, we must be very strict for the movement result and the eyelid position. If we have a secondary ptosis after surgery, we must repair it as soon as possible, because remember that this pediatric patient can develop an amblyopy or lazy eye. And all the post-surgical patients, all the post-surgical pediatric patients must have skioscopy or visual therapy if they need that, if it's necessary, because we don't have to affect the visual acuity for the future in these patients. Remember too that the children gets like more inflammation. So we have to be very carefully with a very depured technique. And I like to use bicryl closing the skin, because maybe it's going to be like redness or more inflamed, more edema, but I don't like to bother the children after surgery to retire the sutures. So it's up to you. You can use Prolene, nylon, but in my personal side, I prefer to use bicryl, because after that, the suture is going to fall down alone. And I don't want to bother another time, put in stress this little child. Sorry. And I think we have 2 minutes. Okay. Orbital tumors surgery tips for beginners. Well, I said that. Always take pictures, always have a very good radiology team for the images, multidisciplinary approach. And if you can do that, ask for some help. Another question, rare presentation of a common tumor. Rare presentation of a common tumor. Well, I remember a dermoid cyst in a 5-year-old girl. It was not the common presentation of the mass in the tail eyebrow. So it was not like the girl in the video. The tumor was inside the orbit, attached to the temporal wall, pushing the eyeball, provoking limitation of the movement and diplopia. And when we sent the tumor to histopathology service, they said that it was a dermoid cyst. but it was not the regular form. It was not well defined. So this is a good lection, to see that it's not a cuisine recipe. We have to abort the patient in an individual and particular form. Well, what else? This is important. What will we do if the tumor cannot remove all? Well, we must remember that removing a tumor is for diagnosis and treatment. So if you cannot remove it completely, you are going to have at the end the histopathology result. And with the histopathology diagnosis, you can offer then other treatment options that could eliminate the rest of the tumor. So always it's better to wait for a diagnosis than damage the tissue that is surrounding the tumor, or damage the eyeball, or damage the muscles of the optical nerve. So, well, I think we are in time. So thank you all for being here in this moment. If you have more questions, after the presentation, you saw my Instagram direction, Ophthalmologa_Marisol. And I'm here to help you if you need some tips or some opinions. So thank you very much for your attention.